Hi, I'm Phil Owen, a peer recovery coach with the Targeted Response Team at Communities for Recovery. Today I have Dr. Aeschbach Jachmann. I hope I said that correctly. She is with Addiction and Psychotherapy Services of Austin. And Crispa, could you tell us a little bit about the clinic and give us a little background on yourself and what you guys do?
Yeah. Hi. Well, I'm a psychiatrist and addiction medicine specialist. So I'm a physician, and I've been working with addiction patients since my time in medical school. And my father is an addiction medical specialist as well and psychiatrist, and he founded our clinic, Addiction and Psychotherapy Services, in 1982. So I kind of grew up with it myself. And the clinic it's the first private methadone clinic in Austin. So we serve patients with opioid use disorder and are a specialty clinic for that. And we also have buprenorphine. And we have groups, and we have individual case managers for all of our patients. And we do tighter buprenorphine treatment than what you would have in an office-based setting. So for buprenorphine, usually patients go to an office the way you would for any other medical condition and get a prescription that you fill at the pharmacy, which is great for some people. But some people need a little bit more help keeping up with their medication and need a little bit more support. And that's where a specialty clinic, getting buprenorphine in a specialty clinic setting, can be really helpful for some people.
Great. So we talk about methadone and buprenorphine.
Yeah.
We will just let everybody know that those are two medications that are used to treat opioid use disorder.
Yes. Sorry, backing up a little bit. Yeah.
That's fine. I just want to make sure we deliver information. I know we've got, hopefully we'll have a lot of family member, friends, and allies also watching. And I want to make sure the information is easy to swallow, if you will.
Thank you, Phil, for keeping me on track. Yeah. So all substance use disorders are recognized now as chronic, potentially relapsing medical conditions. So for opioid use disorder, because it is so devastating and potentially deadly, as we know, we still have our opioid epidemic going on in our country as well. The very clear consensus in terms of what the best treatment is for opioid use disorder is long-term medication therapy with one of the three FDA-approved medications, which are methadone as the oldest and most studied one. It's been around since the 60s and is extremely helpful for a lot of people. Buprenorphine is the second one, and then naltrexone. Vivitrol is the long-acting injectable that some people may have heard of. So those are the three medications, and just that longer-term treatment is the recommended standard of care for the vast majority of people.
And when you say buprenorphine,
yeah.
Some people might know that as Suboxone.
Yes.
The difference?
Suboxone is the trade name. There's quite a few different trade names for buprenorphine. Suboxone, Subutex, Subsol. There are some formulations that are for pain, like Butrans is a patch. So sometimes they're sublingual films that you put in your cheek, and sometimes they're sublingual tablets. They all have the same active ingredient, buprenorphine.
Okay. So if I was to come to you and I'm struggling with opioid use, and I say, okay, well, you've got these three medications, just give me the best one.
Yeah. So what's the best medication for an individual patient is an important discussion to have with your doctor. But some of the things that we think about, or that I think about and most doctors think about when they're seeing a patient, is how severe is their addiction. For people who have very severe addictions, meaning physical tolerance on the one hand, that they're using quite a lot of opioids, if they've really had a lot of major life circumstances because of their addiction, methadone can be a better fit for people with the most severe addictions, and many people with pretty severe addictions. Some of it can have to do with kind of the nuts and bolts of a person's life, where they live, how easy it is for them to get to a clinic. Methadone is a very highly structured treatment, which is federally mandated. There's not a lot of wiggle room in terms of how much take-home medication doses a patient can get. So early in treatment for methadone, patients have to come to the clinic 6 days a week to get an observed dose to make sure that they're taking the dose the way it's prescribed. And on the one hand, for some people that's hard to do, and it's a pretty big imposition, but it's also something that's therapeutic that can be really helpful for some people. And we have a lot of patients who choose to continue to come every day because it gets them started in the morning, and it keeps them on a schedule, and it keeps their life a lot more organized, and they like the support that they get. So it's really very helpful. But for some people, especially people who live farther away, who have a little bit less severe addictions in general, who don't have good transportation, those are people that buprenorphine or Suboxone, Subutex, Zubsolv, that family of medications, or that medication in different forms, can be really helpful for. And again, some people can really manage very well with going to a doctor's office and getting their prescriptions, but it's not as structured a treatment. So for some people, it can work very well, and for others, they start to maybe not take the medication the way it's prescribed, and continue to have some problems, and might need a little bit more structure and help. And then the third medication, the Vivitrol, or naltrexone, is very different from methadone. And buprenorphine are both opioids. They're synthetic opioids, and a person remains physically dependent on the opioids. And that's a question we get a lot. Is it just, changing one addiction for another? And it's very clearly not. While a person remains physically dependent, methadone and buprenorphine have a very different pharmacological profile. So just kind of stepping back a little bit in terms of what is addiction, or what makes something addictive, it's that quick onset of action, right? When somebody smokes a cigarette, or drinks a beer, or takes some pain pills, or injects some methamphetamine, what all of those things have in common is you feel different quickly. Right. And our brains like that feeling, whatever that feeling is, a feeling different. And our brains put those things together. Like, when I smoke a cigarette, it makes me feel different, and I like that feeling, so I'm going to do it again, right?
Right.
And I like to use cigarettes as an example because they're less stigmatized in our society, but it's the same mechanism of action for every single addiction. But methadone and buprenorphine, they don't hit your brain quickly the way that fast-acting opioids do. They both come on very slowly, and once you take them regularly, you have a steady level in your body. So instead of being on this up and down, zigzag intoxication withdrawal cycle that people in addiction are in, people who take maintenance medications, both methadone and buprenorphine, are stable in that, I call it that sweet spot, that place between intoxication and withdrawal where you feel normal. Right. You should feel completely like yourself. You should be free of cravings for the most part. You should be free of withdrawal symptoms. And once you're stabilized, a person takes their medication every day the same way that they would take a medication for diabetes or for high blood pressure or any other chronic medical condition, and work on rebuilding their life or refocusing on their life, ideally working with a therapist or a counselor, or peer supports, and working on all of the other things in their lives that were going on that got them using to begin with.
So to address those, just to address those people that might think it's just swapping one drug for another, would it be fair to say that a medication managed by a professional will always be safer than somebody self-medicating on the streets?
Yeah, I mean, for one thing, you're sure of what you're getting. So one of the big problems with the black market is that you don't really know what you're getting. And especially with pills, there are a lot of pressed pills that have fentanyl in them, or the heroin will have fentanyl mixed with it. And the amount of medication or the amount of illicit substance that somebody's getting can vary broadly. If you're getting medication from a pharmacy and taking it as directed, you know what you're getting. It's been checked to make sure, and if you're taking it the way it's supposed to be taken, so not injecting, you're also really cutting down your risk of infections and overdose. And studies are very, very clear that even for people who do not get to 100% abstinence with methadone or buprenorphine treatment, who continue to use at times, they still have much improvement in their overall health outcomes in terms of their physical health, their mental health, and also bigger societal things like arrests, theft, all these things that kind of, when you look at a society, is it better to have people in treatment or not? Research is very, very clear that as a society, we would be much better off if everybody was in treatment.
Right. It's interesting because in the recovery world, and I'm a person of lived experience, and oftentimes I will hear, well, all we see are people with problems. They go to the methadone clinic and they reoccur and this sort of thing. And I'm like, well, it's because the people that are holding down their jobs, maintaining relationships, advancing in their life, you don't see, because they're function normally and the medication is working. Would that be somewhat accurate to say?
If you sat out in front of my clinic, the vast majority of the people that you saw going in and out, you would never think that just seeing them that they were a person with addiction, right? They don't have any of the signs that we stereotypically and also in terms of stigma, that we stigmatize people with addiction as looking like. We have lawyers, we have nurses, we have soccer moms, and we have people,
Right.
we have construction workers, we have all walks of life, and they're out living their lives exactly as you said, living completely normal lives.
And to be clear, we're not talking about just medication. We're talking about other services. You had mentioned counseling, peer support. It's not just, here's your prescription and get yourself better. We're talking about services around medication. And
that's ideal, but studies are also very clear that people who only take medications are much better off and have much better health outcomes than people who don't.
Right.
So even people who are on waiting lists and are just getting their medication only and not participating in any other services, or people who choose not to participate in other services, we can't force anybody to do therapy or come to groups or participate rather in groups, even people like that do much better long-term on medications than off in studies, right? And that's another thing that's really always a balance. If you're talking about the personal decision for somebody, when you're talking about risk versus benefit, which is always kind of what you're weighing when you start any medication, right? The risks with opioid use disorder are so high in terms of, devastating financial losses, devastation to relationships, devastation to your career, devastation to your health, and the ultimate death. Those are all extremely high with opioid use disorder. And if you're talking about the choice between being at that high risk or being at high risk of relapse and taking a medication every day, I mean, it's kind of I mean, I see the negative sides of taking a medication every day as well, but we have a lot of people who I think probably could get off if they chose to, but they choose to stay on sometimes lifelong because they say, you know what, even if the risk of me relapsing is tiny, it's not worth it to me.
Right.
But that's a personal choice and it's not that I want people to be on medication forever. It's just that if you look at what the potential risk is of relapse, it's huge. So
Let me ask you this. Is there a difference between drug dependence and drug addiction?
so that's a kind of a question about our wording. And dependence refers to physical dependence on something. So if you're taking a seizure medication, or most medications, if you take them chronically, you will develop a physical dependence to varying degrees. Now, some medications you don't notice if you stop them, but your blood pressure might go up a lot, for example. Some medications have a much more clear withdrawal syndrome. And sometimes that can even be life-threatening. For example, with benzodiazepines, like Xanax, Valium, Klonopin, that class of medications, if somebody stops taking them suddenly, you can have a seizure and you can even die.
Right.
Opioids have a very clear withdrawal syndrome that's very visible and very difficult for people to live through. But that's what's going on in your body. Addiction is really going on in your brain. And it's the wanting, the desire, the craving, the changes in your behavior, the changes in your thinking. It has a lot to do with prioritizing the substance over other things in your life. For example, if you're having financial hardship, that $5 that you spend on a pack of cigarettes, you probably really should be spending on something else. But when somebody's addicted to nicotine, it's really hard to make that decision not to buy that pack of cigarettes. So physical dependence and addiction, they overlap. If you think about those diagrams with the two circles, they overlap, but they're not equal to each other. And the other thing to know now, there used to be the names addiction and abuse, which kind of addiction was when you were physically dependent and you had a lot of problems in your life that had to do with the substance, and abuse was more kind of binge drinking on the weekends is a typical example when it caused some problems but wasn't really taking over. So we used to kind of make that, here's abuse and here's addiction. That kind of two dichotomy, that having those two separate things isn't really what we found and a lot of people have experienced. It's not a cut and dry thing. And those words are very stigmatized now. We talk about abusing children. That's a very different thing from abusing a substance, right? Addiction is also a pretty stigmatized word these days. So the new diagnostic name is a substance use disorder.
Right.
So it's that's on the one hand supposed to be less stigmatizing, or is designed to be less stigmatizing, and also there's moderate, mild, and severe, and people can move throughout those categories now. Which anybody who's dealt with somebody in their life with addiction, I'm sure has experienced that sometimes things are worse than others, and it used to be that once you kind of crossed the threshold diagnostically to addiction, you couldn't go back, which doesn't really make a lot of sense.
Right.
So.
Very good. Well, I want to pull your website up on the screen real quick, and I would like to talk about the COVID-19 situation that we're in right now. My understanding is the clinic's still going. It's business as usual, as far as I believe you guys are still taking new patients.
We are.
Okay. I guess so. My question to you is, amidst this COVID-19 situation, what are the challenges and barriers that you're met with?
Yeah. So we're mostly business as usual. We are still accepting new patients Monday through Thursday. We are limiting admissions just because it's harder to do it safely now for our staff and for the patients. So we're limiting to maximum 2 new admissions a day. And and I think all the opioid treatment programs in Texas have really been working very hard to run things as safely as possible. The state, so I mentioned that methadone is very highly regulated. There are strict rules about how much take-home medication patients can get. And the state has, and the federal government, SAMHSA, have really emphasized getting people much more take-home medication than usual to allow them to be home and to maintain social distance. So we have much less people coming in and out of our clinic on a daily basis. Most our stable patients are mostly home and coming in every 2 to 4 weeks. So for people who are new coming in, we have a lot, we're disinfecting, we're having our patients wear masks, we're only having a limited number of people in the lobby. We're doing a lot to keep things safe on the one hand for both our staff and people seeking treatment. But we do want to be able to keep bringing people into treatment and making that available.
Okay. So I guess what I would like to ask then is, coming out of COVID-19, wherever that might start to happen, can you look into your crystal ball and tell me how services might change?
Yeah.
Think they'll
So
change at all?
for methadone, I don't think a lot will be changing. The laws around methadone are pretty strict, and I think that for most people they're helpful. I don't see that changing. What has changed for buprenorphine, for Suboxone treatment, and for the treatment of other disorders that require controlled substances. So that includes ADHD or the benzodiazepine medications that we were talking about before. One of the major things that has happened is there's a federal law called the Ryan-Haight Act, excuse me. And it says that a physician must have at least one face-to-face appointment with a patient before starting a controlled substance. So that really limited the use of telemedicine for opioid use disorder, for buprenorphine, for Suboxone treatment. And that has been temporarily lifted in the state of this crisis. So, methadone treatment right now is much more focused on making sure patients are home as safely as possible. And but buprenorphine can be started right now just through telemedicine.
Okay.
So, and if people are interested in getting into buprenorphine treatment, this is a time where that is much easier to do. We're working, and you showed our website, we're working on getting a telemedicine clinic set up to be able to prescribe buprenorphine, for me to be able to prescribe buprenorphine through telemedicine remotely. And that's a big change for treatment. And it really opens it up to people who live in more rural areas. For Texas, you know, we have huge parts of our state that are underserved, especially along the valley area, our whole Laredo. There are places where there's a lot of illicit opiates, a lot of heroin coming over from Mexico, a lot of people with opioid use disorder, and very little access to treatment. So in terms of what's going to change, I hope that, and I think it's possible, that they may open up buprenorphine to telemedicine in the future. And that's something that ASAM, the Organization for Addiction Medicine Specialists, they've been really lobbying for that to be opened up too. So,
yeah, that's great. I know rural areas have really suffered with regards to aid and medication-assisted treatment, and that would be awesome to see that come out. My understanding is too is that Medicare and Medicaid are paying for telemed services now.
They are, and that's not clear if that's going to go on after this crisis or not. But they really have opened up, and you know, the government tends to move slowly on things like this. But in the face of this crisis, they have been very quick, and the DEA has been very quick in, for example, allowing these changes with methadone clinics, allowing the change with controlled substances. In some states, they're allowing physicians to practice in other states where they don't have a license. That varies from state to state. In Texas, you have to have a Texas medical license to prescribe, and I only have a Texas license, so my buprenorphine clinic would only be open to people in the state of, who are physically located in the state of Texas.
Right. That's, you know, and I'd want to do a show on supports in rural areas come out of this, so maybe we can have you back for that. It's all great talking with you. I want to leave you with one last question, and that is, if you could create your own flavor of ice cream, what would it be?
Ooh, I would say a lemon cookie.
Lemon cookie, awesome.
Yeah.
Great. Well, thank you so much for being on here. Oh, one last thing. How can a new patient or somebody get in touch with services?
Yeah, with our clinic, just checking out our website, seeing if our services look like we're a good match, and calling to do a phone screen with one of our nurses is a great way to start, or just coming. We do in-person screens Monday through Thursday. You need to arrive at our clinic between 6 and 7 a.m.
What is that phone number to contact?
Yeah, the contact is 512-444-5092 is our phone number, and our website is austinmethadone.com. And like I said, I'm hoping to get the information on our telemedicine buprenorphine clinic up by next week. So
great. Well, Dr. Aeschbach Jachmann, thank you so much for being on. I really appreciate having you, and thanks for all the information.
Thank you so much for doing this. It's a great service to our community.
You bet. Thanks everybody for tuning in.